Hello, my name is Dr. Jenny Murase, and I'm Associate Clinical Professor at University of California, San Francisco, and I direct medical consultative dermatology at the Palo Alto Foundation Medical Group. I've had an interest in psoriasis in pregnancy for over 20 years of my career, and in particular, caring for female patients with psoriasis is something that I feel very strongly about, and I really love educating the public about the importance of having the right discussions and informed decision-making prior to the birth of a child, of a woman who is on therapy for her psoriasis. There are certain considerations that come into play when you are selecting therapy during pregnancy. So first of all, for any woman of childbearing age, because 50% of pregnancies do occur without consulting any physician, it's very important to have discussions prior to initiating pregnancy. And for any woman of childbearing age on narrowband UVB light treatment, I recommend that a woman take folic acid 1 milligram a day in order to prevent neural tube defects, because over time, narrowband UVB has been shown to decrease folic acid levels, and it's very important to maintain folic acid level stores prior to pregnancy. When selecting a biologic therapy for a woman who is pregnant or considering pregnancy, it's important to consider how much safety data is available for that patient to guide them. The TNF alpha class of psoriasis biologics have the most safety data available, so I tend to feel the safest in recommending that class of therapy. There are few data for IL-17 and IL-12-23 agents during pregnancy. In addition, the pregnancy itself can be therapeutic for the psoriasis. So there are about 50% of women that actually get a respite from their psoriasis during the course of the pregnancy. So it's important to take that into consideration as well when developing a therapeutic regimen for a pregnant patient, because oftentimes they do not need the same amount of therapy that they did before they were pregnant. In addition, it's important to consider the immunosuppression of the fetus. If this is a child that is born to a woman who is on some kind of biologic therapy, biologic therapies tend to be IgG large molecules that really have to cross to the baby through the placenta. There is an Fc portion of the antibody that the syncytial trophoblast will grab onto in order to actively pull the antibody across the placenta in the last few weeks of the pregnancy in late third trimester. So during the first trimester, there really is no antibody transfer. It starts in the second, and there's an exponential increase right before delivery in order to prepare the child for the birth, in order to protect the child. And so really the transfer of the vast majority of the biologics does not occur in the first trimester when organogenesis is an issue, but it will occur later in the pregnancy, and those antibodies will be delivered to the fetus. There was a fetus who was born to a mother who had Crohn's disease in an area of England that was endemic for tuberculosis, and that child was born healthy but died at age 4.5 months, which was 1.5 months after receiving a live vaccine, the BCG vaccine, which was given to the child because of the area that they lived in was endemic for tuberculosis. So they wanted to make sure that the children born in that area were protected from tuberculosis. So the child was immunosuppressed as a result of the biologic, and therefore it is very important to make sure that no live vaccines are given to children who are born to women on biologic therapy. And also, it is a counseling point that the child will be immunosuppressed. There is a medication that does not have that Fc portion that is called Cimzia or certolizumab. And so that is a particularly safe biologic agent to give in a pregnant woman. Also etanercept, which is also a TNF-alpha agent, it crosses by simple diffusion. So the levels also in cord blood are very, very low. They range about 4% to 8% of maternal levels versus those that will be actively transported, such as adalimumab or infliximab, which will be at 150% of the mother's maternal levels. So it is really those two therapies for severe psoriasis, including light therapy and biologic therapy, that are currently considered the safest forms of therapy for women with psoriasis.